Now we will move on to our Q&A session. And for the Q&A session, I would like to invite Drs. Cortes, Robson, Hurvitz, and Klemp for the discussion. Just as some information, today we have 900 registrants from 47 countries who are attending this meeting. So thank you for supporting this meeting. For the Q&A session, we'll start with a couple of challenging cases, and we'll also field your questions. So please provide your questions in the chat section, and we will try to answer as many of them. So we'll start with a case first. This is a 42-year-old with a clinical T2N0 grade 3 TNBC that was 3.5 centimeters on exam and imaging. She received neoadjuvant Taxol Carbo Pembro, followed by AC Pembro, the 522 regimen, and underwent a mastectomy with sentinel lymph node biopsy. There was no residual disease in breast and 3 negative sentinel lymph nodes, so had a complete pathological response. Genetic testing that was done at the time of diagnosis shows a pathogenic BRCA2 mutation. So the questions for our panelists are, what would you recommend adjuvant pembrolizumab for this young lady, and what are your thoughts on adjuvant olaparib? Maybe we'll start with Dr. Cortes first.
Sure. So thank you very much. Good afternoon, morning, good evening, everybody. So I think this is a good prognostic patient, I guess, stage 2 with a great pathological remission after pembrolizumab-based therapy. According to the keynote 522, we know that we have improved disease event-free survival with pembrolizumab up to 1 year. So I think that without further data, I would support the use of pembrolizumab if possible. Regarding adjuvant olaparib, this is a patient with pathological complete remission. So I think that with the data we have today, I would not give this drug. So we continue with pembrolizumab, and that's it.
Dr. Robson, what are your thoughts?
No, I agree with Dr. Cortes. I mean, with a pathologic complete response for triple negative disease, they don't meet criteria for, or she didn't meet criteria for Olympia. And so there's no evidence that adjuvant olaparib is going to help her in this setting. And while we're all kind of going back and forth about how much of a role the post-operative pembro is playing, right now the data are what they are with the regimen that used it for a year. And so I think we're stuck until we have data otherwise.
And so at your institution, that's what the routine recommendation is, regardless of the pathological response, to continue with the pembrolizumab.
Yeah, we're just following keynote 522, just right down the line.
Okay. Next slide. So in terms of the BRCA2 mutation regarding surveillance, this patient does not have a family history of ovarian cancer and has one paternal uncle with pancreatic cancer who was diagnosed at age 80 with that cancer. She has 2 children and has completed her family. What should we be telling her about prophylactic surgeries, the timing of those surgeries in terms of ovarian cancer risk, and what about pancreatic cancer screening?
Would you like me to take that? So for BRCA2, ovarian cancer risk before 45 is actually pretty limited, but 40 to 45 is the usual recommendation. For BRCA1, we usually say 35 to 40. So I think it's reasonable for her to have a BSO. I don't know if she's had bilateral mastectomy or just unilateral mastectomy, but obviously she does have contralateral cancer risk. And so if she still has a breast, she needs screening for that. Pancreas cancer screening is really a challenge. It's one of these things that has crept into practice basically without evidence. The AGA is recommending pancreas screening for people who have alterations in close relatives with pancreas cancer, and they're recommending either EUS or MRCP with a preference for endoscopic ultrasound. But honestly, the little bit of data that comes out of the registry studies is not particularly encouraging in terms of the ability to detect early stage disease. So it's one of these settings where things are being offered without a whole lot of evidence. So we don't routinely do pancreas cancer screening off study, and the only people we refer to study are those with first degree relatives that are affected.
So in this individual, since that's not a first degree relative, there wouldn't be any active screening, just recommendations to watch out for signs of, weight loss, jaundice, and those types of things.
Yeah, I mean, as you know, I mean, pancreas cancer is a scary thing, especially if you've had it in your family. And so even if somebody's risk is only 5 to 8%, it's still pretty terrifying. And the idea that they're sitting there with that risk and not doing anything about it is frightening to them. And I think physicians, and particularly gastroenterologists, tend to respond to that.
Mm-hmm.
There's just no clinical evidence that it's useful at this point.
Dr. Hurvitz, any thoughts?
Yeah, the only thing I'd add to what Mark was just saying is that, often BRCA2 mutation carriers will have hormone receptor positive disease. And if that was the case here, and it wasn't somebody treated with Pembro, and she's 42 and has gone through a mastectomy and it's hormone receptor positive, I consider the BSO recommendation not only for risk reducing, but also risk reducing for recurrence of breast cancer. So I have had that occur a few times where I take into consideration the subtype of the breast cancer when we're weighing together the timing of oophorectomy. But I agree completely with what Mark said. And the pancreatic cancer screening is sort of like ovarian cancer screening. It's, we do the CA-125, we do the ultrasounds, et cetera, until a patient has their ovaries removed. But how much that's actually impacting long-term outcome by catching it by one of those mechanisms is entirely unclear. And I think a lot of this just goes into making the patient feel like they're being surveyed closely and making the physician feel like they've got their finger on the pulse. We just don't know if it's improving outcomes long-term.
Yeah. And, I think some of it also gets challenging for programs that have the gastroenterologists running some of the high-risk GI clinics because, we have such a program. So automatically these individuals will get referred there. And then they have some differing recommendations that they receive from there based on the GI Society's guidelines versus what they're being told. So I feel like for many of these patients, I end up having to order, EUS alternating with MRI or MRCP every other year because that's what they've been told. And then I'm unable to provide enough evidence to walk them down from it. So it certainly is challenging. As we're doing more and more panel testing, we're finding genes that have some association with pancreatic cancer. That's hard to screen for. I want to ask Dr. Cortes, what are you doing at your institution in these types of situations?
So no, I couldn't agree more with both Sara and Mark, but I want to be very honest. When you talk to the patient, the risk of other cancers than ovarian and breast cancers, and you discuss the risk of gastric cancer, pancreatic cancer, whatever, in some cases, in a face-to-face way, I have done annual MRIs to rule out pancreatic cancer. I know that we do not have this data, but sometimes for patients, it's not just you have data or you don't have data. It is an in-depth discussion. So I have done sometimes, but I agree that this is something that we do not have data to support it.
So we'll move on to our next case. Great discussion.
One last comment, if you don't mind, because one of the questions was about what about if residual disease here? And I think it's difficult to know, should we continue with pembrolizumab? Should we continue with olaparib? What about combining both? Well, I don't know in the United States if you have the possibility to combine both. This is what I would love to do, but in many countries, for sure, it is not allowed. And I think that I would consider the residual cancer burden. So if this is RCB 0 or 1, maybe I would continue with pembrolizumab. If not, maybe I would continue with olaparib. But this is just a feeling. This is what I would do without further data.
So in this situation, if this patient hadn't achieved a PCR and you have both olaparib and pembro as options, ideally one would like to do both, but that may be limited by what's available and what's approved by insurance. But if one was forced to choose one or the other, then that does become an issue. What are your thoughts about it, Mark?
I think, as Javier says, I think a lot of it has to do with, I mean, for me, it has to do with what they got, right? So if they truly got the full 522 with carbo and they've got tons of residual disease, I'm not super excited about olaparib in that setting. If on the other hand, they got a little bit of residual disease and I had to pick one, I might just go with olaparib. The question that comes in is, would you skip Xeloda altogether? So the way I've reasoned this out is that with a little bit of residual disease, we know that in both Olympiad and Embraca, in the metastatic setting, single agent PARP inhibition, was more effective than physician's choice chemotherapy, and the most commonly selected physician's choice chemotherapy was capecitabine, and objective response rates in the patients with measurable disease were roughly doubled with the PARP inhibitor compared to physician's choice chemo. So I think that you combine those observations with the pretty miserable outcomes from the ECOG study in terms of how people did even with CAPE, and I would just go with the PARP inhibitor.
And if you could, you'd do the pembro with it, but if you had to pick one or the other, you'd base it on what they got before surgery, and if they got all the platinum, then you'd be less enthusiastic about a PARP inhibitor.
Particularly if they had a substantial amount of residual disease. If they looked like they were really carbo insensitive, then although we don't really know what the response rates are to PARP inhibitors in that setting, the data from the Abrazo trial suggests that they're not going to be as good. It's just kind of a phase 2 of talazoparib, and response rates in truly platinum refractory patients were not good.
So I haven't yet encountered this situation, so I haven't needed to order the two together. So I'm not sure what the particular insurance carriers would do here in the United States. I wonder if Sara or anybody else here has had encountered this situation.
Encountered the situation trying to use pembrolizumab followed by or in combination with olaparib?
In combination, yes.
I haven't done that yet. I haven't encountered it. I have ordered olaparib for patients. It's not yet approved, I don't think, and I haven't run into problems with that in patients who are appropriate, but haven't yet had, and I imagine it's only a matter of time. We're going to have more and more patients who have received pembro in the neoadjuvant setting where we're going to have to address this. Mm-hmm. And the other question I come up with is, what about the use of pembro plus Xeloda, which I think some of us are tempted to do, especially in the platinum refractory setting, as Mark indicated, for heavy disease burden. And that's something I'd be tempted to do. There's some data relating to the safety of that combination. But again, you have to take into consideration how beat up the patient is at the time that they're coming to you in terms of chemo tolerability and bone marrow capacity, et cetera.
All good points. Yes. So, we're going to be encountering situations in clinic which haven't been addressed in trials, and some of them are likely not to be addressed, to make decisions based on the patient preference, what they can tolerate, and in some cases, what we have access to in terms of insurance barriers. So we'll move on to our next case.
Do you want to ask about the ctDNA maybe, though?
Yes, let's move on to the next case.
Great.
So this is a 52-year-old lady with HER2 positive, ERPR negative, de novo metastatic breast cancer, presented with liver and bone disease, received first-line THP, followed by HP for 18 months, and had good disease control. However, now has progression in liver and was found to have 2 brain mets and received SRS to these brain lesions. And the question is, what would you recommend as next line of therapy? If you can click the next button, David. So here are some potential options, and of course our discussion doesn't have to be limited to these options, but this is a second line treatment recommendation with progression in liver, and new brain mets. Dr. Hurvitz.
Yeah, so here we're dealing with a second-line setting, and until recently, we didn't have a lot of data to support moving away from the standard TDM1, but with the data that Javier first presented at ESMO from Destiny Breast 03, where TDXD really beat TDM1. I mean, there was no way to see the data any differently with a hazard ratio of 0.28 in terms of progression-free survival. I think that sort of firmly plants trastuzumab deruxtecan in this second-line setting. Now, this patient who has brain metastases, she was able to have SRS to the lesions. So on the Destiny Breast 03 study, patients with stable treated brain metastases were allowed, and about 15% of patients fell into that category. Interestingly, we did observe by blinded independent central review some responses in the brain with TDXD, which is sort of challenging our thinking about ADCs and the ability to treat brain metastases. So I think TDXD would be my option here, my preferred option, given she has extracranial and intracranial disease, and the intracranial disease has been treated locally. Number two, the tucatinib-based therapy would certainly be an option available, and it's also an FDA-approved option. Although it wasn't tested in the second-line setting like this patient finds herself in the HER2 CLIMB study. So I would probably reserve that for the next line of therapy, just looking at the relative PFS, objective response rates, et cetera, seen in HER2 CLIMB and Destiny Breast 03. That's how I would order them.
Dr. Cortes?
I think it's difficult to add a single word to what Sara has said. Absolutely agree with everything. Nothing to add. This patient, by the way, did not fulfill the criteria for her to climb for two reasons. The second line, but also because she did not have previously received TDM1. This was a requirement. So definitely I would go for TDXD here.
Next slide. So for whatever reason, the physician decided to go with the CAPE trastuzumab tucatinib combination, and she had a nice PR that was durable for 9 months. And this is something that we encounter as we use this combination in clinic is, you've been on it for a while, and what do you do with CAPE? Can one stop it? The patient not having extreme toxicity, but moderate PPE, which is requiring supportive measures and some alteration in the capecitabine schedule to do one on, one off. How do you manage this in practice? Because there are many patients that stay on it for a very, very prolonged period of time.
Yeah, that's a really good question. And I do think we have to keep in mind, although patients live quite a long time with HER2-positive metastatic disease, it is still the palliative setting. And so quality of life needs to be a high priority in the treatment of our patients. In HER2 CLIMB, patients could drop one of the agents if they were developing toxicity due to it. So if she met criteria to drop capecitabine on this study, she would have been allowed to continue on the other agents. The problem is we don't have really good data to tell us whether that impairs the PFS or OS long-term by completely dropping it. So in my own patients, my preference is to drop down the capecitabine to the level where the patient is really feeling quite good and experiencing as little side effect as possible. A little anecdote, I had a patient who I treated with TH-based therapy 10 years ago. She progressed, went on TDM1, progressed, and then we put her on lapatinib, capecitabine. And she's been on it for years now with the capecitabine dose of only 500 milligrams BID, because that's what she could tolerate. And has had this, prolonged durable response. So that would be my preference based on my own anecdotal experience and the way the clinical trial was designed, where you can drop it down as little as possible. I wouldn't totally drop it unless there was a lot of toxicity, But this is an area where we don't have a ton of data, so I'd be interested in hearing what my colleagues are doing in their practice.
So you would drop the dose down instead of stopping it completely. Dr. Robson, what are your thoughts?
My thoughts are I can't get unmuted. So, I mean, I have nothing to add. Of course, when you got Javier and Sara going first, I mean, what else is there to say? I agree with Sara. I would just kind of we go to 1 week on 1 week off very, very quickly in metastatic setting, and I can't feel comfortable just abandoning the CAPE. And so if I can get it down to a tolerable dose, even if it's 500 BID, that's what I would do. If it was absolutely intolerable, then I guess I'd stop. But you can usually find some dose that they can continue on.
So the consensus would be that try to stay on it at some dose instead of completely dropping it. And with something like CAPE, we can usually come up with some level of dosing that's not too harsh on quality of life for these patients. Okay, so we'll move on to the next question. Next case. This is a 36-year-old Caucasian G2P2 female with first live birth at age 26 and family history of breast cancer diagnosed in a paternal aunt at age 45. No other cancer in the family. The Tyrer-Cuzick lifetime risk of breast cancer is 15.5%. And genetic testing is complete negative for clinically significant mutation. However, the polygenic risk score estimates lifetime risk of breast cancer at 22%. So, Mark, you addressed this in your talk, and the question is, how should you manage this patient in terms of screening?
Yeah. So I think it's difficult when you're kind of presented with a number that exceeds a threshold to walk away from it. There's the one thing I just really dislike about all of the estimation tools, whether they be Tyrer-Cuzick or whether they be this polygenic risk model, is that there's no estimate of uncertainty, right? And so you get these very specific estimates, 13.25% or 36.3% at 10 years. And honestly, there's a band around that. And it's not really accounted for in the reporting. And is there a meaningful difference between 15.5% and 22.5% in terms of this person's true individual risk? And so the philosophical answer to that is probably not. But technically, since they are over 20% in the United States, you could offer this person MRI screening. I think it would be a conversation. How concerned is she? Does she want to do it? You can offer it to her. I mean, what's the value of MRI screening at 22.5%? Hard to say, although the Dutch did do a study looking at familial risk only and familial risk of greater than 20%. And they did show increased sensitivity of MRI screening over conventional screening in that setting without survival outcomes. But nonetheless, the diagnostic yield was definitely higher. So I think it's a reasonable thing to offer to her, but then with this explanation that I'm not really sure that does that much difference, and you now happen to exceed this arbitrary threshold. And to continue my rant, there's nothing about 20% that has any validity or reality in life. It's like age of 50 as a threshold for whether or not an oncotype means something. It's exactly the same thing, that we just picked 20% arbitrarily out of the thin air. And whether that's the correct threshold to start doing screening from a cost effectiveness or an outcome standpoint is completely unknown. So thank you. I'll get off my soapbox.
So, my question is, like, when you get these reports, and as you brought up oncotype, you get a score and you get a risk, but there's a range or a confidence interval around it. So you can, and do you see a future where those would start to be provided? As you rightfully pointed out, this is, there's a range around it, and that sometimes is helpful.
Yeah, I mean, there's we're doing an interesting experiment now that I mentioned in the talk, which is that we're giving the RCA carriers back a risk-adjusted estimate, and I felt very uncomfortable when we were designing the study giving them a precise point estimate, and so we tried to design a measure of uncertainty, and this gets a little bit into the weeds, but each estimate of risk from a particular allele for polygenic risk score actually has a 95% confidence interval around it because it's calculated through a chi-square in case control analysis. And so if you take the lower and the higher estimates for each allele that you're feeding into the polygenic risk score, you wind up with a very wide band of possible outcomes. And so that for us is part of the reason why we're not seeing a whole lot of impact on women's decision making is when you tell them, yeah, okay, your point estimate is at the lower end of the risk, but our uncertainty is fairly broad. It definitely undermines the potential utility. I personally think it's a more honest way of doing it, but it's a challenge for interpretation.
I'd like to add in too that to your point, Dr. Robson, I think that patients will hyper-focus on that specific number when it is a range. And I think the best thing we can do for the patient is to explain this is a range. It's sort of our own standard deviation sometimes, but that hyper-focus can be really stressful for patients as they're trying to make decisions.
And as Dr. Robson pointed out in his talk, that I love that, you know, for that individual patient, it's either 0 or 1. I mean, it can be whatever percentage, but it is going to be yes or no at the end. We just don't have better precise estimates to tell that individual how close we are to be able to predict that yes or no case. I want to ask. Go ahead.
I'm sorry. I mean, the challenge is, I think, that women themselves translate the number into 0 or 1, right? And the point at which they look at a number and say, well, that's a 1, I'm going to go have surgery, or that's a 0, I'm not going to do anything. You know, most people are not particularly good at probability or matching probability to dichotomous action. And so that's one of the reasons I don't like the precision, is because it gives us this estimate of almost implication of certainty that the women take on board and use it for decision making.
I want to ask Dr. Cortes about, you know, your guidelines and thoughts about MRI screening in your country and institution for high-risk women, or additional screening beyond mammography.
No, so I think that MRI is only possible to be done when you have a BRCA1 and or 2 germline mutations for a follow-up. That's it. However, I think that, as you said, Priyanka, you have the patient in front of you. The patient has had probably triple-negative breast cancer, whatever. A very close family at the age of 45 had also breast cancer. Definitely, I would not go for double mastectomy, but so it is not cost-effective. I completely agree. But annual MRI, if the patient wants to do it and she can do it, I think it's nothing, you know, very complex. So again, I don't know, but I would discuss with her the possibility to do an annual MRI, and probably I would suggest to do it if she can pay for that or she has a good private insurance. For the community, unfortunately, I agree, this may be not cost effective. So I don't know if this is something we can recommend, but in a face-to-face, in a case by case, I think that this is something for sure to be discussed.
Thank you. So we'll move on to our next question. Case. So this is a 42-year-old with clinical T2, clinically node positive, grade 3 TNBC, received a regimen similar to 522 and underwent a mastectomy. At surgery, she has 1.1 centimeter residual disease in the breast, but all the nodes are negative. This is calculated to be RCB2. And the questions here are, in the setting of residual disease, you know, what are our recommendations? capecitabine. She's had both a checkpoint blockade and carbo in the neoadjuvant setting. Does that impact your recommendations for capecitabine, since we know that the CREATE-X trial obviously didn't, those patients didn't get pembro or carbo. And then the question that we briefly touched on earlier is doing the two drugs concurrently versus sequentially, if both are recommended.
So maybe we can start. I think this is something we discussed before. We do not have this data because in Keynote 522, I think like 20 patients or so received CAPE and it was not allowed per protocol. Nevertheless, in the clinical practice, I agree, Mark and Sara said before, that they would continue with pembrolizumab. I would do it as well, but I think it's less to lose just combining with CAPE. So I would include CAPE, but it's very clear that if we have to give CAPE, it is just after surgery. If we have to continue with pembro, just after surgery. So I would give both concurrently.
And then this patient, given node-positive disease as presentation, in most centers would be recommended for radiation as well. So the sequencing challenge for radiation, the CAPE and the pembro, and those are all practical considerations for us in practice. So how do you address those? Would you recommend the patient get the radiation first, then move to additional systemic therapy, or use some sort of sandwich approach?
So I would continue with pembro and radiation therapy, and just after radiation therapy, I would start with CAPE.
Okay. How about you, Dr. Hurvitz? Any additional thoughts?
No, I agree. I mean, I think we have some nice early phase data indicating synergy with radiation and immune checkpoint inhibition. So I tend to use the two together. I agree doing the capecitabine on top of that, I think might be a little bit much in terms of skin toxicity, potentially heme toxicity, and just overall not doing well. When I'm using capecitabine alone in a patient who didn't receive pembrolizumab, in that situation, I will carefully administer CAPE concurrently with radiation, but I work really close with rad-onc when I'm doing that and sometimes have to dose reduce.
So, a question had come up regarding ctDNA monitoring, and I had it queued up on this case as well. So the patient is inquiring about the role of ctDNA testing for MRD monitoring in this patient, and what are our expert panels thought about it. There's a lot we've seen about ctDNA and MRD in TNBC in the last year and a half.
I'll jump in there really quickly and just say it sort of triggers me because you can do a lot of these tests and have this information, but to what end? Having prognostic information really doesn't help anyone unless we have demonstrated that that knowledge helps us predict benefit by changing our course of action. And to date, we do not have that data. We have ongoing studies. So what I do is refer patients to trials that are evaluating ctDNA and addressing randomizing to a new therapy versus not. But right now it's just information, which can be quite disturbing. And remember back in the 90s when all those studies were done with bone marrow biopsies, I think led by the Germans, showing that patients who had micrometastases in the bone, guess what? They had a worse outcome, but not all of them had their disease recur. So women were sort of troubled with this knowledge that they had a likelihood of having a worse outcome with no evidence that changing therapy would alter that outcome. So that I'll step off my soapbox now because maybe my colleagues have a different way of looking at it.
So,
no, I don't have a different way of looking at it. I mean, I'll join you in the triggered category. I think, I mean, unfortunately, I think ctDNA is probably even worse in terms of prognosis than CTCs were. And it looks like in the small studies that have been done, if you do have ctDNA, your likelihood of relapse in a relatively short period of time with triple negative disease is extremely high. And yet, you're talking about somebody who's gotten carbotaxol, pembro, AC, CAPE, radiation therapy. I mean, what the heck are you going to offer them outside of trial? I mean, clearly an adaptive design using an ADC would be the next kind of most interesting thing to do. But that would need to be done on a study in order to see whether or not it had any benefit. You're not just going to throw SASE on somebody on a ctDNA test. So we don't use it here outside of trial.
Dr. Cortes, any additional thoughts?
Absolutely agree with both of them. Nothing to add.
Yeah, it is something, though, we find ourselves talking to at least the educated patients out of in this setting quite often in clinic. The tests are available, the companies are advertising it and all of that. So it does just make it harder, but we need some well-designed trials to address this question of whether it's just a harbinger of metastatic disease that's going to develop regardless of what you do, or can you really treat MRD to go back into remission. There's a couple of questions that I'm just going to take that came from our audience. One was regarding a patient that, and we can assume maybe that patient had triple negative disease, and an elderly patient that had weekly Taxol and carbo in neoadjuvant setting, and I'm assuming that this regimen was chosen because of the patient's age or performance status, and then now has residual disease, and we don't know exactly how much, but must be substantial for the provider to think about what else to do with this individual. In terms of systemic therapy, would you now offer this individual checkpoint blockade or capecitabine or the two together? How would one approach this? Dr. Cortes?
So I would start.
Yes.
Okay, so if taxanes plus platinum compounds and residual disease, so I would give CAPE for sure. But the question here is, outside clinical trials, we do not have any data showing the benefit of checkpoint inhibitors only in the adjuvant setting. So I don't know. So my point here is, should I give anthracycline-based therapy 4 times at least or not?
Mm-hmm.
So if the patient is not frail, I think I would offer anthracyclines followed by CAPE in this case. That's why I don't like not giving everything. I like anthracyclines, although, again, in this patient, if I can do it, I would go for anthracyclines followed by CAPE. If not, just CAPE.
So if the patient is, even though they were elderly, but they look robust enough to take the rest of the good chemotherapy, one would offer it. Otherwise, at least offer capecitabine in the setting of residual disease.
That's for sure. That's for sure.
And of course, the role of pembro when it hasn't been given preoperatively is undetermined. SWOG 1418 should answer that, and we should see that report sometime next year, hopefully, and that randomized patients after receiving chemotherapy without immunotherapy to receive pembro or not for a year in the setting of residual disease. But till then, it's still kind of data-free zone. And especially, it's happening less and less now because more and more patients are now being treated with preoperative immune checkpoint inhibitor. But, in the last 6 months, we've all seen more patients in our clinic that were before, the approval that had just gotten chemo and now have residual disease. And, they were met the guidelines to be part of 522 type of regimen. So you always struggle with that question of should you now prescribe just the adjuvant part of pembro or not for these individuals.
No, and outside of the United States, pembrolizumab basically is not approved yet in the early breast cancer setting, neither in Europe. So I think that this is something that happens many, many times, and many more people are giving taxanes plus platinum compounds without anthracyclines. So this is something that we are seeing many, many times, again, outside the United States. So this is a question which is really very, very important for the clinical practice.
Yeah. In terms of adjuvant pembro only for somebody who's received all good chemo ahead of time and just, was diagnosed before the approval or for whatever reason didn't get it, What are your thoughts, Dr. Hurvitz and Dr. Robson? Are you feeling tempted to prescribe it, or how are you handling that? We obviously won't know anything from 1418 for another year or so.
We just don't know. I have a discussion with patients. I think right now capecitabine has more data supportive of its use in the adjuvant setting than single agent immune checkpoint inhibitor. And, there's a mechanistic reasons for why after removing the tumor, use of immune therapy may be less effective. So I'm reticent to. I discuss the options with the patient. You run into, I think, hurdles with insurance companies as well, using a very expensive IV drug, pembrolizumab, in the adjuvant setting if you haven't followed the 5-2-2 regimen.
Yes. I think there were a couple of other questions regarding high risk with mammographic density. Jen, did you want to?
Yeah,
Yes.
I put a note in the Q&A for the audience too. I think in regards to Jennifer's question about enhanced screening in a patient with no family history but other risk factors who has a 20% risk, greater 20% lifetime risk. Dr. Robson, I'd like to hear your thoughts, but we do at our institution offer that to them. But I do think it requires kind of that shared decision-making discussion about what type is best, and because once you add enhanced screening, what's the frequency of that, short-term follow-up, all the things that happen from doing more screening. So Dr. Robson, what's your thought on enhanced screening without the family history, 20% lifetime risk?
So I think that the evidence suggests that MRI is going to be more sensitive than conventional screening in whatever setting you use it in. And the hassles of MRI are obviously insurance coverage and cost, false positivity, which is a bigger issue in the first image than it is in subsequent images. And, this free-floating concern about gadolinium exposure. But if we could get, rapid MRI sequencing or, shorter studies that are less kind of annoying, and I don't see any reason not to use it in somebody who's high risk, particularly if they're younger and have mammographic density, which we already know is going to compromise conventional screening. We do actually have a reasonable amount of contrast enhanced mammography here, which is not necessarily a widely deployed technology, but in these kind of intermediate cases, sometimes we'll do CDM rather than do MRI, just because people don't really like MRIs. They're uncomfortable, they're long, they're expensive, and if you can do it as part of a mammo, you might be able to get just as much of a bump.
So I'll ask one practical question about TDXD as we're using it more and more in practice. In the patients that went on trials, typically they had scans like every 6 weeks, and that may be one of the ways that we're monitoring for asymptomatic ILD and stopping and intervening early. How do you address this in clinical practice now? And we have patients stay on it for quite some period of time. Are you stretching the length of the scans out to 3 months? And then do you worry that you may miss asymptomatic ILD in these patients? And of course, it's been challenging with COVID because, as our patients are getting COVID, then we're starting to see some of those changes on the scans as well.
Yeah, we really need more data regarding this entire question, because we're very conservative on Destiny Breast 03 and held TDXD for asymptomatic suspicion based on scan alone, which makes us all wonder whether we need to be doing Q6-week scans throughout a patient's being on this for years, several years. And that's just a lot of radiation exposure, and it's maybe overkill. So we need more data regarding how to monitor patients appropriately, whether we can resume after grade 2 ILD in patients who recover, because right now you permanently discontinue, whether we can be using PFTs or DLCO to help pick this up. There are just so many unanswered questions. So my hope is that trials will further interrogate how to best manage this. And I know Javier has some strong sentiments on this as well. He and I both get kind of worked up when we talk about this because it's such an important side effect of this drug.
what are your thoughts? Should
100%
so
agreement.
keep doing scans every 6 weeks for now till we hear more? Yes, that's radiation exposure, but I worry about stretching it out too long. Maybe 9, but even for those that have been on for over a year, I haven't felt comfortable going every 3 months yet, because I'm using that as a way to look for ILD. And I don't is there some reassurance that once you've been on it for a year that the risk of developing ILD now is lower? So our
No, I
studies.
mean, it can happen later. So I think time isn't the answer. I agree. I think 6 to 9 weeks is reasonable. And patients being really in tune with pulmonary symptoms and calling even if they get a chest cold, just so that we can watch it very closely.
Well, I think we're about out of time. This was a fabulous discussion. I want to thank all our faculty for their insightful comments and answering questions not live during the discussion, but staying active in chat and simultaneously answering several of our audience's questions in chat. We will now have a quick break and we'll be back at about 11:35.